Welcome to the funnel effect. Today we're jumping into something really significant, a major shift in how we think about pulmonary hypertension, or PH. It's a complete redefinition, really, and it changes the management approach, too.
It really is a fundamental overhaul driven by new evidence. Our guide for this discussion is an excellent clinical primer by Dr. Bradley A. Marin titled Revised Definition of Pulmonary Hypertension and Approach to Management, which came out in the Journal of the American Heart Association.
Yeah, it's a great piece. So our goal today, our mission, if you like, is to unpack why these diagnostic numbers for PH have changed so dramatically. We're moving away from, what, decades of consensus.
45 years, roughly, moving from that consensus to thresholds based on actual patient outcomes data.
And we really want to understand what this means for catching the disease earlier and ultimately for patient survival.
Absolutely, because PH, it's a tough disease. Highly morbid, comes in many forms. You see it across general medicine, cardiology, pulmonology.
And the big problem has always been the delay in diagnosis, right? Often years.
Yeah, typically around 2 years from symptom onset to actual diagnosis. And that delay, it's directly linked to worse outcomes, higher morbidity, shorter lifespan. This whole redefinition is really about closing that gap, identifying people sooner.
Okay, let's get right into it then. The core change. The numbers. For ages, clinicians used one specific pressure measurement to define pH. What was that old standard?
The classic definition was a mean pulmonary artery pressure, the MPAP, of 25 millimeters of mercury or higher, measured by right heart cath, of course.
25. And you said that number wasn't really based on hard data showing that's where the risk starts.
Exactly. It was established way back in the 1970s, based largely on expert opinion at the time. There just wasn't the kind of large-scale outcomes data we have access to today. It sort of became dogma over time.
So decades of dogma overturned. What's the new standard? What do the recent data show?
The new definition, confirmed by right heart cath, or RHC, has two parts now. First, the MPAP threshold is lower. It's now greater than 20 millimeters of mercury.
Okay, so down from 25 to just over 20. That's a significant drop.
It is. And second, critically, there's a new requirement. An elevated pulmonary vascular resistance, or PVR, of greater than 2 Wood units. You need both MPAP over 20 and PVR over 2.
Right, the PVR. Let's clarify that. MPAP is the pressure, like blood pressure in the lungs. What exactly is PVR measuring in layman's terms?
Think of it like resistance in the pipes. If the MPAP is the pressure the right heart has to generate to push blood through the lungs, the PVR measures how much friction or blockage there is within those lung blood vessels.
So diseased, narrowed vessels mean higher resistance.
Precisely. Healthy, wide-open vessels have low PVR. Diseased, stiff, narrowed vessels, what we call vascular remodeling, cause the PVR to climb. It measures how hard the right ventricle has to work against the state of the vessels themselves. 2 Wood units is now considered the upper limit of normal.
Got it. So what specific evidence showed that the danger zone really starts at an MPAP over 20?
It came from large contemporary studies looking at big patient groups. Using sophisticated analysis, they found a clear, continuous increase in the risk of death and hospitalization, starting right when the MEAP crossed that 20 millimeter mark.
And 20 MPP and 2 Wood units PVR, you're saying those are basically the upper edge of what's considered physiologically normal.
That's right. So the new definition essentially says as soon as you cross the upper boundary of normal, that's where the disease definition begins, because that's where the risk demonstrably starts to increase.
Which means a whole group of people who were previously told they were borderline or high normal, they now officially have PH.
That's the key takeaway. This reclassifies a substantial number of patients. The evidence is telling us that even these mildly elevated pressures and resistances aren't benign. They signify an active disease process that carries risk.
I recall a striking statistic from the paper in one large study. This new definition picked up something like 60% more patients.
That's right, roughly 60% more compared to the old definition. It's a massive expansion of the diagnosed population.
60%. That really changes the landscape.
It absolutely does. It shifts PH from being maybe a more niche concern to a much more common issue that primary care doctors, cardiologists, pulmonologists will encounter. The driving idea is if we catch these people earlier, when the MPAP is between 20 and 25 and the PVR is maybe 2 to 3 Wood units,
we have a better chance to intervene before things get really bad.
Exactly. Before the right ventricle undergoes significant, potentially irreversible damage from the chronic pressure and resistance overload.
Okay, but let me ask the tough question here. With this mild group, MPAP 2025, How sure are we that the increased risk isn't just driven by other problems, comorbidities, rather than the mild pH itself, especially in older patients or those with heart failure?
That's a crucial question, and the researchers addressed it. These modern studies are designed to adjust for comorbidities. While things like left heart disease definitely contribute, the analyses consistently showed an independent risk linked to the hemodynamics starting right at MPAP over 20.
So even controlling for other factors, the pressure itself is a problem.
The consensus now is that even this level of pH is pathogenic per se. It's causing harm on its own, driving adverse remodeling in the pulmonary vessels and the right ventricle, even if other conditions make it worse. The goal is to identify that hemodynamic problem early.
Okay, that clarifies the why behind the numbers.
Uh-huh.
Now let's talk causes. pH isn't just one thing, is it? It's grouped based on the underlying problem.
Correct. Management depends entirely on the cause. We classify pH into 5 broad WHO groups. Group 1 is pulmonary arterial hypertension, or PAH. That's disease in the small pulmonary arteries themselves.
Okay.
Group 2 is PH due to left heart disease pressure backing up from the left side. Very common. That's PH due to lung diseases or hypoxia, like COPD or interstitial lung disease. Low oxygen constricts the vessels.
Group 4 is blockages.
Right. Pulmonary artery obstructions, mainly chronic thromboembolic PH, or CTEPH, caused by old blood clots?
And group 5 is sort of a catch-all.
Exactly. Undifferentiated or multifactorial causes.
Cause?
Think sickle cell, sarcoidosis, other systemic conditions.
Now, for a clinician seeing a patient with shortness of breath, which of these are they most likely dealing with? What's the prevalence breakdown?
By far the most common are groups 2 and 3. PH due to left heart disease probably account for 50 to 70% of all cases.
Wow, the majority.
Yeah, and KH due to lung disease is next, maybe 30 to 50%. So together, those two make up the vast bulk of PH seen in practice.
That's really important because group 1, PAH, which gets a lot of attention regarding specific drugs, is actually much less common.
Much less common, comparatively. But let's touch on PAH first because the treatment is so specific. What drives group 1 PAH? It's often disease of the tiny arterioles in the lungs. It can be idiopathic, we don't know the cause. It can be hereditary. Or, importantly, it can be triggered by certain things.
Like drugs?
Yes, definitely drugs.
Yeah.
Methamphetamines are a big one. Some older diet pills, anorexogens, even certain cancer drugs like dasatinib. It's also strongly linked to conditions like scleroderma, particularly limited cutaneous systemic sclerosis, HIV infection, and liver disease leading to portopulmonary hypertension.
So a really thorough history, drug history, social history is vital if you suspect PAH.
Absolutely critical.
Now, group 4, CTEP. You mentioned this is the one we absolutely can't miss. Why is it so crucial?
Because CTEP is potentially curable. It happens when acute pulmonary emboli, blood clots, don't dissolve properly. Instead, they organize into scar tissue that obstructs the arteries.
And if you catch it.
If you diagnose it correctly, many patients are candidates for a surgery called pulmonary endarterectomy, which physically removes that chronic clot material. It can be a complete cure for the PH.
A cure. That's a world away from managing other forms of PH.
It truly is. Even if someone isn't a surgical candidate, there are other effective treatments now, like balloon pulmonary angioplasty or medical therapy with riociguat, but that potential for a surgical cure makes early and accurate diagnosis paramount.
How do you typically screen for CTEP?
The go-to screening test is usually a VQ scan, a ventilation perfusion lung scan. It looks for areas of the lung that are getting air but not blood flow, which suggests obstruction. If that's positive, it leads towards further imaging and ultimately RHC.
Okay, moving on to the diagnostic journey itself. We know it's often delayed. What are those early symptoms that get missed?
They're frustratingly vague, which is why the delay happens. Early on, it's mostly just dyspnea, shortness of breath, especially with exertion and maybe reduced exercise capacity.
Like I get winded going upstairs now?
Exactly. Things they used to do easily become difficult. And it's often chalked up to aging, being out of shape, maybe mild asthma. It doesn't scream serious lung vascular disease initially.
Compared to advanced PH, which sounds much more dramatic.
Oh, absolutely. Advanced PH presents with clear signs of the right heart failing. That can mean chest pain, often from the right ventricle struggling for oxygen, syncope or near syncope, fainting or nearly fainting with activity is a really ominous sign.
Why does that happen?
Because the right ventricle simply can't pump enough blood forward through the high-resistance lungs to meet the body's demands during exertion. And you also see signs of fluid backup, leg swelling, abdominal bloating, symptomatic heart failure.
So if someone presents with that unexplained shortness of breath, the first test is usually an echocardiogram, right? A TTE.
Yes, the transthoracic echo is the standard initial screening tool.
And what's the key echo finding that suggests pH?
We look at the speed of blood leaking backward across the tricuspid valve, the tricuspid regurgitant jet velocity, or TRJV. A velocity over 2.8 meters per second generally suggests high pressures in the pulmonary artery, corresponding to a systolic pressure around 35 millimeters of mercury or more.
Okay, 2.8 meters.
Mwah.
Sounds useful. But the source material really hammered home the limitations here. Why isn't the echo definitive?
There are major limitations. First, it's an estimate of pressure, not a direct measurement. And the accuracy depends heavily on image quality.
Acoustic windows.
Exactly. Patients who are obese or have severe lung disease, like COPD, often have poor acoustic windows. The ultrasound just can't get a clear view, making the TRJV measurement unreliable or unobtainable.
So technical issues. What's the other big problem? Sensitivity.
That's perhaps even more critical. Studies show that about 1/3 of patients who do have pH confirmed by the gold standard RHC actually have a non-measurable or normal TRJV on their echo.
1/3. So the echo misses it completely in a huge chunk of patients.
It absolutely can. So a normal echo in a symptomatic patient does not rule out pH. You can't stop there if your clinical suspicion is high.
That seems like a major reason for diagnostic delay right there.
It's a huge factor. Also, the echo can't reliably measure the pulmonary artery wedge pressure, the PUP, which you absolutely need to tell if the pH is coming from the left heart or the pulmonary vessels themselves.
Okay, so TRJV is one clue. What other things on the echo support a pH diagnosis? What does the heart itself look like under that strain?
We look for signs of the right heart struggling. Is the right atrium dilated? That suggests pressure overload. We measure the size of the right ventricle compared to the left ventricle at the base. If the RV-LV ratio is greater than 1.0, the right ventricle is abnormally enlarged.
Now the shape changes too.
Yes, you look for flattening of the wall between the ventricles, the interventricular septum. High pressure in the RV pushes it over into the LV cavity, creating what's called the D sign on certain views. That's a classic sign of RV pressure overload.
Does the echo also tell us how well the right heart is actually working?
It does, and that's critical for prognosis. We measure something called TPSE, tricuspid annular plane systolic excursion. It basically measures how much the base of the right ventricle moves up and down as it contracts.
And a lower number is bad.
Very bad. A TPSE less than 1.7 centimeters indicates reduced RV systolic function and is a strong predictor of worse outcomes. So the echo helps flag patients who are already in trouble.
So to sum up, TTE, useful screening, points you in the right direction, gives prognostic clues, but definitely not sensitive enough to rule out pH and doesn't give all the numbers needed for classification.
Precisely. Which brings us back to the gold standard.
The right heart catheterization. RH.
Mandatory. It's the only way to directly measure the pressures, MP up, PWP, calculate the PVR accurately, and figure out the exact hemodynamic subtype, which is essential for deciding on the right treatment.
Okay, let's dive into those RHC numbers now. We know MPAP over 20 and PVR over 2 defines pH. But the classification depends on the wedge pressure too, right? The PWP.
Exactly. And just to reinforce, even that mild pH group, MPAP 20-25, PVR 2-3 isn't benign. We now know it's associated with real physiological changes and worse outcomes down the line. It's pathogenic.
So we need to clearly separate the hemodynamic profiles based on RHC. This dictates treatment. What are the three main subgroups?
It all hinges on where the primary problem lies, pre-capillary in the pulmonary arteries, post-capillary, back up from the left heart, or a combination.
Let's start with the classic target for the advanced therapies. Isolated precapillary pH. What defines that?
This is where the resistance is high within the pulmonary vessels themselves. The criteria are MPAP over 20, PVR over 2 Wood units. And crucially, the PAB, the wedge pressure reflecting left atrial pressure, must be 15 millimeters of mercury or less.
That low PAW-P is key.
It's key because it tells you the high pressure isn't just backup from the left side. So this profile is typical for Group 1 PAH, Group 3 lung disease PH, or Group 4 CTEPH.
Okay, now the most common type, isolated postcapillary pH, driven by the left heart.
Right, this is basically high pressure backing up. The criteria here are MPP over 20, but the PVR is normal or low, 2 Wood units or less. And the POP is high over 15.
So high pressure, high backup pressure, but the vessels themselves haven't become diseased yet.
Exactly. The high POP confirms the left heart origin. like heart failure, either preserved or reduced ejection fraction. The normal PVR means the pulmonary vasculature itself is relatively passive, just dealing with the back pressure. Management here is all about treating the left heart.
And the third type sounds like the most complex. Combined pre- and post-capillary pH?
It often is. This means you have both problems. Criteria: MPP over 20. PVR is high over 2 Wood units, indicating vessel disease, and the POP is also high over 15, indicating left heart backup.
So the vessels themselves are diseased and there's back pressure.
Yes. It's often seen in long-standing or severe left heart disease, where the chronic back pressure has actually caused secondary damage and remodeling in the pulmonary vessels, or sometimes in patients with both heart and lung disease. This group generally has a poorer prognosis because you're fighting disease on two fronts.
That really underscores why you need all three numbers. MPA, PVR, and POD-W from the RHC. You can't manage it properly without them.
Absolutely essential.
You also mentioned something called exercise pH. What's that?
This is an interesting, still evolving category. It's for patients who have exertional shortness of breath, but their resting RHC numbers are actually normal, and their left heart function is fine.
So the pH only shows up under stress.
Right. It's diagnosed during an exercise RHC. The definition is based on how much the pulmonary pressure rises relative to the increase in blood flow, cardiac output during exercise. Specifically, an MPAPE cardiac output slope greater than 3 millimeters of mercury per liter per minute indicates an abnormal vascular response to exercise.
Suggesting the vessels can't handle the increased flow properly, even if they seem okay at rest.
Precisely. It might reflect early, subtle vascular stiffness or dysfunction that only becomes apparent under stress. It's an area of active research.
Okay, let's pivot to management, focusing first on Group 1 PAH, which needs that specialized approach. Given the importance of early treatment, when should a clinician absolutely refer a patient to a dedicated PH center?
Referral needs to be quick for suspected or confirmed PAH. Key triggers include rapid symptom progression, like worsening functional class, say, going from WHO class 2 to 3rd within just a few months. Any patient presenting already in WHO class 3 or free needs immediate expert evaluation.
What about specific danger signs?
Definitely syncope or near syncope with exertion. That's a major red flag for RV failure. Any clinical signs of right heart failure, significant edema, elevated neck veins, or echo findings like severe RV dilation or that low TPSE we talked about.
Any other group?
Yes. Also, any patient with known PAH risk factors who is pregnant or wants to become pregnant. Pregnancy is extremely high risk in PAH and requires very specialized management.
Once they get to the center, for certain types of PAH, idiopathic hereditary drug-induced, there's a specific test they do during the RHC, right? The vasoreactivity test. Why is that still done?
It's crucial because it identifies a small subgroup, maybe around 10 to 12%, who respond dramatically differently to treatment. The test involves giving a short-acting pulmonary vasodilator, usually inhaled nitric oxide, during the cath.
And you're looking for a specific response.
A very specific response. You need the MPA to drop by at least 10 millimeters of mercury and reach a final MPA of 40 millimeters or less without the cardiac output decreasing.
Why the caveat about cardiac output?
You need to ensure the pressure drop is due to the vessels actually relaxing, vasodilating, not just because the heart is failing and can't pump as much blood.
Right. And for the small percentage who meet these strict criteria, what's the treatment?
They are candidates for high-dose oral calcium channel blocker therapy drugs like nifedipine or amlodipine. These drugs are generally not effective and can be harmful in non-responders.
But for the responders?
For the true responders, the results can be incredible. Over half of them can achieve a sustained, dramatic, almost near-curative clinical improvement. It's a profoundly different long-term outcome compared to non-responders. That's why we still test.
That difference makes the test absolutely essential. Now, for the majority, the 85–90% who are non-vasoreactive, how do we approach them? It depends on risk.
Yes. Management is heavily risk stratified. We assess risk based on symptoms, WHO class, exercise capacity, like the 6-minute walk distance, biomarkers like NT-proBNP, echo findings, and the RHC numbers themselves.
What defines high risk?
High risk would be things like WHO class 3 or 5e symptoms, maybe syncope, a very low 6-minute walk distance, very high NT-proBNP, signs of RV failure on echo, and really bad hemodynamics, say a low cardiac index under 2.0, or a very high PVR, maybe 12 Wood units or more.
And for these high-risk patients, the strategy is now quite aggressive from the start.
Yes, the recommendation is for upfront triple combination therapy. Hit the disease hard with drugs targeting 3 different pathways right away.
What does that typically involve?
Usually involves a parenteral or subcutaneous prostacyclin analog. These are the most potent vasodilators, often given via continuous pump, plus an endothelin receptor antagonist, or ERA, and a phosphodiesterase type 5 inhibitor, a PDE5I.
Wow, 3 major drugs immediately. And for intermediate risk patients.
For those not meeting high-risk criteria, the standard initial approach is usually dual combination therapy. Typically an ERA plus a PDE5I taken orally, like ambrisentan and tadalafil, for instance.
But the key is follow-up.
Constant, close follow-up and reassessment. The goal is to get the patient into a low-risk state quickly, within maybe 3-6 months. If they don't reach low-risk status on dual therapy, you escalate rapidly, often adding that third agent, potentially a prostanoid.
Can you briefly list the main classes of drugs we're talking about for PAH?
Sure. There are basically 5 classes targeting 3 main pathways. 1, the prostacyclin pathway. Includes 5-epiprostanol, inhaled iloprost, subcutaneous or IV treprostinil, and an oral agonist called selexipag. Powerful vasodilators.
Okay.
2, the endothelin pathway, blocked by ERAs like bosentan, ambrisentan, and macitentan. Endothelin is a substance that constricts blood vessels.
Got it.
3, the nitric oxide pathway, enhanced by PDE5 inhibitors like sildenafil and tadalafil, and also by a soluble guanylate cyclostimulator called riociguat. These promote vasodilation.
And the goal of all this therapy is to reach low risk. What does that look like?
Low risk means aiming for minimal symptoms, WHO class 1 or 2, good exercise capacity like a 6-minute walk distance over 440 meters, low NT-proBNP levels, ideally below 300, near normal echo findings, and improved hemodynamics on repeat RHC, like cardiac index above 2.5, low right atrial pressure. Reaching and maintaining low risk is strongly associated with better long-term survival.
Okay, this detailed PAH management is crucial.
Yeah.
But now we absolutely have to shift focus to the most common scenarios, PH related to left heart disease group 2 and lung disease group 3. Let's start with LHD-PH, potentially up to 70% of cases. What is the single most important warning about using those PAH drugs here?
The warning cannot be emphasized enough. The advanced PAH therapies we just discussed, especially ERAs and prostacyclin analogs, have not shown consistent benefit in LHD-PH. In fact, they can cause significant harm, particularly pulmonary edema.
So using a potent pulmonary vasodilator in someone whose high lung pressure is due to backup from left heart failure.
That's dangerous. Well,
Think about it hemodynamically. Their problem is high pressure in the left atrium, high polyp. If you aggressively dilate their pulmonary arteries with a drug like a prostacyclin, you lower the resistance, PVR, allowing more blood to flow into the lungs easily.
but that blood then hits the high-pressure wall on the left side. It can't get out easily. So fluid rapidly shifts out of the capillaries into the lung tissue itself. That's pulmonary edema, fluid in the lungs, which can be life-threatening. We're essentially flooding an already congested system.
That makes perfect sense. So the strategy must be completely different.
Hmm.
What is the recommended approach for LHD-PH, especially in HFpEF, heart failure with preserved ejection fraction?
The absolute focus has to be on aggressively managing the underlying left heart disease. That means optimizing volume status with diuretics, managing blood pressure, using guideline-directed medical therapies for HFpEF like SGLT2 inhibitors, possibly mineralocorticoid antagonists. Treat the heart failure first and foremost.
And ideally refer them.
Yes, referral to a specialized center that deals with both PH and heart failure is often best, especially for potential clinical trial enrollment, as the optimal approach is still being worked out for many of these patients.
Is there any role for pulmonary vasodilators in LHD-PH? Any niche?
There is a very limited cautious potential role. In patients with LHD-PH who also have severely elevated PVR, indicating that combined pre- and post-capillary picture we discussed. Specifically, a PVR greater than 5 Wood units, a careful trial of a PDE5 inhibitor like sildenafil might be considered.
But only maybe to help symptoms.
Exactly. The goal would be palliation of symptoms or maybe improving exercise capacity, but it requires extremely careful monitoring, objective assessment like checking the 6-minute walk distance or biomarkers, and if there's no clear benefit, the drug should be stopped promptly. It's not a routine therapy.
Okay, very clear distinction. Now, what about the other common scenario? PH in patients with interstitial lung disease, ILD, group 3. Here, the lungs themselves are scarred.
Right. This is another complex group. The PH is often driven by destruction of the lung capillaries by the fibrosis, as well as by low oxygen levels, hypoxia.
Is there any targeted therapy here?
There is one specific therapy with some evidence. For ILD patients with pH and significantly elevated vascular resistance defined in the trial as a PVR greater than 4.0, would units initiating inhaled prostacyclin therapy, specifically inhaled treprostinil, is considered reasonable.
Based on what data?
It's based mainly on one randomized controlled trial, the INCREASE trial, which showed that patients on inhaled treprostinil had, on average, an improvement in their 6-minute walk distance of about 33 meters compared to placebo over 16 weeks.
33 meters. That's modest, but potentially meaningful for someone very limited.
It is statistically significant and potentially clinically relevant for some. However, there are major caveats.
Such as?
Translating this trial result into widespread practice is challenging. Inhaled therapies require significant patient adherence. They can have side effects like cough and throat irritation, and they are extremely expensive.
So the real-world benefit versus burden isn't fully established yet.
Not definitively for all patients. It requires careful patient selection and discussion. For many ILD-PH patients, the mainstay of management remains optimizing treatment for the underlying ILD itself, providing supplemental oxygen to combat hypoxia and pulmonary rehabilitation.
So again, the specialized PAH drugs have a very limited, carefully selected role outside of true Group 1 PAH.
That's the critical message. You have to diagnose the type of PH correctly using RHC before even thinking about specific therapies.
Okay, let's synthesize this. This deep dive really highlights a paradigm shift, doesn't it? The new definition, MPAP over 20, PVR over 2, it's fundamentally a preventative strategy.
Exactly. It's about identifying the disease much earlier in its course, based on evidence showing that risk starts sooner than we thought. The hope is to intervene before the right heart sustains major damage.
And the practical result is this huge new group of patients diagnosed with mild PH, MPBate 2025, PVR 23. For them right now, management is focused on finding the cause, fixing risk factors, watching them closely.
Correct. We identify them, classify them hemodynamically, address underlying LHD or lung disease if present, manage risk factors, and monitor. But we don't yet have proven therapies specifically targeting this early stage, especially if it looks like early PAH.
And that brings us perfectly to the big unresolved question, the provocative thought to leave our listeners with.
Right. All the landmark clinical trials that prove the effectiveness of our current PAH drugs, the ERAs, PD85s, prostanoids, they all enrolled patients based on the old, higher definition, MPP over 25, usually with a PVR of 3 or more.
Meaning, for this massive cohort of mild PH patients identified by the new definition, we actually don't have solid evidence that these expensive, potentially side effect-laden drugs provide meaningful benefit at that very early stage.
That's the crux of the issue. Does treating someone with an MPAP of 22 and a PVR of 2.5 with dual or triple therapy actually change their long-term outcome compared to watchful waiting and risk factor management? We don't know yet.
So the challenge for the field now is enormous. How will clinical trials be designed, and how will guidelines evolve to figure out the optimal, cost-effective, and safe way to manage this huge group of newly diagnosed mild PH patients? That's the key question for the next decade, isn't it?
It absolutely defines the next frontier in PH research and clinical practice.
Thank you for watching The Funnel Effect.